So it's my pleasure to quickly introduce Dr. Vader and Dr. Zuckerman. So Dr. Vader is the Chief Clinical Officer at Hackensack Meridian Health, and Dr. Zuckerman is a board-certified infectious diseases physician also at Hackensack Meridian. So I'm going to hand it over to them for their
Dr. Zuckerman's
presentation.
The head of infectious disease for the whole network.
For the whole network. Apologies.
Well,
Okay.
thank you. A month ago, I think we were kind of at the valley. We're beginning to climb up again for the next drop. So I'm going to give an update on current trends and just a little bit about vaccine updates, and then mostly open it up to questions. I think it's really important that we recognize that this week we've passed the 1 million mark of deaths in the United States due to COVID-19. This started out in March 2020, and just a little over 2 years later, over 1 million of our fellow citizens have passed away. And this was a shot from, I believe, the fall, when there were only about 600,000 deaths, but there was a flag planted for every death in front of the Washington Monument, and really speaks to the impact that COVID has, not on our lives, and then obviously on people who've had this unfortunate outcome. So, looking at deaths during this whole pandemic, this is looking at the number of deaths, the ratio of deaths to the positive test. And the thing I want to show here is that when we first started out, there was a higher death rate. We didn't know what disease we were dealing with. We were all susceptible to it. And we had very limited testing, so people were presenting very late in their illness. And obviously it was very devastating at that time, primarily in the Northeast, and certainly New Jersey and New York were kind of the epicenter during that first wave that we saw back in March and April 2020. But you can see that it has become less deadly over time. Doesn't mean that less people have died, but if you are getting infected, there's a smaller chance that you may die, though it still approaches about 2%. I think this is due to several things over time. So one is we've learned how to treat the disease, especially for hospitalized patients. We have medications available now, and strategies to treat seriously ill individuals. And most importantly, starting in December 2020 and January 21, we had vaccines that became eligible and were introduced, and have also had a tremendous impact on the lessening the severity of disease and people who were dying from their infections. If you look at who died, this is primarily was in the older population, and we know that elderly people who get viral illnesses have a higher likelihood of complications than a younger person. Many older people have other illnesses like heart failure or lung disease, and sometimes they have very little reserve, so that an infection can just put them over the edge so that they aren't able to recover from the infection or from the exacerbation of their heart disease or lung disease. So primarily in those individuals over the age of 65, but we did have, younger individuals die, over 250 children less than 1 year of age, had passed away from this. So clearly a relationship between age and outcome. And there's also, this has also affected different communities and based upon their economic and social status. This is looking at death rates by all counties. And if you look at the percent of the population in poverty in that county, it was, if it's higher than 17% of the population was in poverty, they had a higher death rate than individuals with a lower county population, a county with lower prevalence of poverty. Similarly with uninsured and the social vulnerability index. And I think it clearly speaks to some of the what's the word I'm looking for? It'll come
contributing factors, risk factors.
Well, equity of care is not exactly the word I was looking for, but it speaks to why are some of these issues present. Some of it may be lack of access to care. Some of it may be lower vaccination rates and belief in the vaccinations. I think there are many factors involved. It was interesting that there was an article in the New York Times, I think this past weekend, which compared the death rates in Australia versus the United States. And Australia has a very similar demographic population as the US, but Australia has probably closest to the lowest death rate in the world. And really, it had nothing to do. I mean, we obviously have the most sophisticated medical care in the world that we can deliver, but in their analysis, it really was trust. It was trust in the science and trust in the public health. And there was a wide difference between what that trust level in Australia versus someplace like the United States. And I think that the lack of trust really kind of fractured our way that we approach this disease, and instituted collective actions rather than individual ones. So these two slides. So this here is looking at it's a marker for the number of people who've had COVID infection. And so it's measuring a certain antibody, and if it's positive, it means that you've been infected in the past. You can see that younger individuals, this is that red line here, age up to 17, almost 60% of them by January 2022 have had an COVID infection. And the percentages of the population decreases as you get older. So 40% of those individuals between 18 and 49, slightly 35% for 50 to 64, and closer to 25% for age 65 and up. So the younger you are, the more likely you had natural infection. And then this side here shows vaccinations. And it shows fully vaccinated. The pinkish lines here are the older population. So this is over 75 years of age, 65 to 74. And then the yellow is the younger population. So what we see with vaccines is the reverse of what we saw with the natural infection. So more of the older population has been vaccinated than the younger population. But if you put all of it together, there's a large percentage of our population who has either been infected with COVID or been vaccinated against COVID, if you put these two populations together. Yet, despite that, we're seeing another kind of round of COVID infections. And so this is looking at New Jersey and looking at the community transmission levels in the state. I believe probably the last talk I gave was sometime around here, but you can see that we're all red, meaning that there is a high level of transmission in the community. And so if most of us have been infected or vaccinated, why is this still happening? And I think this really gets back to how the virus evolves over time. And I've shown this slide previously, so some of you have seen it. This is just an example of I think this was what we call the alpha strain, but all these yellow things were mutations. The virus, replicates and mutates, and this was the Omicron. So these were significant changes. And the reason the virus mutates again is so that it can survive. It wants to, and survival is measured by how easily it transmits between individuals and how well it evades our ability to respond and kill off the virus. So what's happening now from Omicron is that there are now what's called subvariants. So there are slight changes in the virus, and which makes the virus even more transmissible between individuals and alters it enough so that our antibodies and things that fight off infections are less active against that subvariant. And so because of that, we're seeing that, the protection from either previous infection or previous vaccination are waning, and we can get reinfected or infected in the first time if we were previously vaccinated. So this is looking at the variants in the United States. This light purple here was what we called the original Omicron strain. This was a variant called BA.1.1, and then that was subsequently, there was a new variant, that subvariant BA.2, which was had an advantage over the other one, and now we have another one called BA.2.121. So the only point of this is that there are subtle changes to the virus that allows it to keep circulating around and evading our immune system. And that's why we're seeing these kind of persistent cycles of infection that are occurring. So this is looking at the United States, and going back to the beginning of the pandemic. This large spike here, this is number of cases per day. We hit over 800,000 in the US, and that was during the Omicron surge in January. We reached a nadir in March and April, and you can see that there's a slight uptick again, and we're approaching, having 100,000 infections in the US on a daily basis again. And that's probably underreported, because what we have now that we didn't have before is many people have home tests, right? So you can do a home test. You might have, requested it and they got it in the mail. And so if you do a home test, you may not necessarily report it to the public health department, so you wouldn't be counted as having COVID. So it's likely that the number of COVID infections in the community is higher. But what we're not seeing, so this is hospitalizations, and this is severe disease, people going into the ICU. And you can see that certainly we are not seeing severe illness this go around. There's been a slight uptick in hospitalizations, but not to the extreme that we saw previously. And we're not seeing a rise in deaths at this time. Now, this may be because, we're still early in this surge, and these things will tend to follow 2 to 3 weeks later. But it also may be because, as I showed you, many of us have either been vaccinated or had an infection and have some immunity that helps make the infection, if we get the infection, less severe and makes it more mild because we have some protection. We're not totally vulnerable to the virus like we were back in March of 2020. So hopefully this will continue to look like this. It's really still early in this wave to tell, but that's certainly my hope. So, vaccines continue to be the singular most important thing to prevent severe infection, prevent dying from COVID, and it does protect against getting infected in the first place, but less so. So the point of vaccines, as we've seen how it evolves, is not necessarily to prevent an infection from occurring, but preventing you from getting seriously ill and ending up in the hospital or in the intensive care unit or worse, dying from the infection. So these are some of the vaccine schedules that, for different ages, there are different recommendations. I will say that the J&J shot, the Janssen shot, is not recommended. The FDA at the beginning of this month said that because of some of the complications that people had when they got the vaccine, that it should not be administered to anyone in the future unless that individual has no other alternative. If they're not a candidate or can't get Pfizer or Moderna, that would be the vaccine of last resort. So, if someone came to me and requested, because they heard Johnson & Johnson and was 1 or 2 shots, I would not give it to them. I would strongly go for the Pfizer and Moderna because of the safety profile. If you did get J&J, it doesn't mean that you are at risk now for any of these complications. These are things that happen, within the weeks after you first get vaccinated. So for people whose immune system does not work very well, they're recommending, additional booster doses. I should probably start with this slide first. So this is for normal people who have a normal immune response. For a fully vaccinated individual was considered to have completed the 2-shot series, which is the primary series. And then what became available in the fall of 21 was the booster dose. So people who get the primary series plus a booster are considered up to date with their vaccination. And then most recently, I believe, I think it was February, the FDA approved an additional second booster to be administered to individuals over the age of 50, individuals who have other immune system problems. So it's not for everyone in the general population, but for select age groups. Not select age groups and those with select other illnesses that they may have. This was just happened today. So Pfizer is the only COVID vaccine that's approved for 5 to 11 years old. It's a 2-dose series. And today the FDA just authorized a booster dose to be allowed to be administered to kids between the ages of 5 and 11. And that would be 5 months after they complete their series. So that's hot off the press. The reason, so if you see here, the primary series is 2 doses. If you are someone whose immune system doesn't work well, we actually recommend that primary series to be 3 doses. So we want to because sometimes you don't respond as well as to 1 or 2 doses and really need the 3rd dose to kick in your immune response to the vaccine. So this shows the death rates since vaccines have become available. There's always been this difference between unvaccinated individuals, vaccinated and boosted individuals. Individuals who are unvaccinated have and will continue to have a higher risk of dying from COVID infection than those who have been vaccinated or have been vaccinated and received a booster. Clearly, that has been shown to be very protective against that serious outcome. And this is looking at age hospitalizations. And again, you can see a discrepancy between those who are unvaccinated versus those who are fully vaccinated or fully vaccinated with a booster. And these differences become much more evident when there's tons of disease in the community. And when disease starts, is at lower levels, those differences will start coming together. But if we shoot up again to the levels that we saw in January, I am sure you will see these curves spread again, and the unvaccinated will have worse outcomes. So what I continue to recommend is that people ask, should I get a booster? I will say that if you have not gotten a booster, I would absolutely recommend getting a booster. The quote up to date of COVID vaccination status is completing that primary series and receiving a booster. That is, I think, really has held up well in ensuring that your disease infection, if you do get one, would be less severe. Whether you get a second booster or not, I think depends. So it depends on your individual risks for severe disease. So if I'm immunocompromised, if I have cancer, or if I have a kidney transplant, yeah, I would strongly consider getting the second booster. Also, you have to consider your individual lifestyles and occupations, and are you constantly in an area where there's a potential risk for exposure to COVID, and you don't want to, you want to minimize your chances of getting it, then that would be another, reason to get the second booster. And then looking at what's occurring in the community and which viral strain is circulating. So, knowing right now that the subvariants are not that all different from the Omicron, that, there's still good protection there. But if the virus should change markedly, like we saw when it changed into Omicron, like I showed before, with multiple changes in the virus, then that would make our antibody levels less protective and would be definitely a strong indication to get a booster at that time. So it's really, unless you are severely immunocompromised or elderly, and elderly being, older than me, but older than 75, then those groups I would strongly recommend. If you have individuals living in a nursing home, outbreaks could occur there. So as much protection as you can provide, I think is critical. And then the other thing, I don't have a slide for this, but I also, we have therapeutics now that we didn't have before, and there are pills that individuals can take, antiviral pills, that can lessen the severity and decrease the likelihood of progressing to severe disease or requiring hospitalization. That pill is called Paxlovid. It does, it's available in pharmacies. And, I think one of the problems is that the provider community is either not fully aware of the medication, or because the medication may interact with other medicines, a little concerned or timid about prescribing it because of that concern about drug interactions. And, some of this stuff, like if I'm on a medicine to lower my cholesterol, and that interacts with Paxlovid, it's okay if I stop the cholesterol medicine for 5 days, right, and take the other medicine, because what's my immediate threat is the virus, not my cholesterol. I think if it's important just to remind the community that there are oral treatments available to individuals if they do get infected, no matter what their vaccine status is. These may be medications that are valuable for an individual to take. And I think, Melanie, that was my last slide. So I will stop sharing.
Great, thank you. Dr. Bader, did you have anything?
No, that was an excellent update. Thank you, Dr. Zuckerman. Really, I think we don't mean to press too strongly on one message, but obviously, Dr. Zuckerman makes a very compelling case both for vaccination as well as for the boosters. And I would say that, I can't speak for Dr. Zuckerman, but we're both of sort of a moderate risk in terms of our age and all of those things. And I've just gotten my second booster, meaning my 4th dose. So just obviously that's the most important message anybody can walk away with. And I think the second thing is, we didn't really touch on pregnancy, but because I'm an OBGYN, I always like to touch on the safety of the vaccines throughout pregnancy, and the fact that the disease, COVID, has been demonstrated not only, unfortunately, to kill women, but fortunately, even though that's relatively unusual for young women, but also COVID can also have significant cause significant complications during pregnancy. And then the final message is, I think sometimes there's so much information, and again, I know information is helpful, but sometimes we see so much information that it's hard to lose it's easy to lose the simple message. And I just do want to emphasize that point. I thought that graphic that Dr. Zuckerman showed with the state turning redder and redder and redder, we've been through this before, but you can't let your guard down, because this is definitely a real disease, and cases are going up. I know that there's people talk about mask fatigue and COVID fatigue, and the FAA's rule about wearing masks on planes and things like that was just lifted. But I just want to urge people to continue to take the appropriate precautions, and in particular, besides vaccination, also staying home when people are ill, getting tested to make sure that you're not spreading it, because this is still a deadly disease, even though fortunately between vaccination and improved treatments, it's not as deadly as it once was. Thank you.
Yeah, and Melanie, just to, I didn't discuss, and we didn't discuss, the masking and the social distancing and staying home. I didn't not discuss it because it's not important. It still is important. We all go out, and we probably see much less masking in public now than we've seen previously. And whether you mask or not, again, gets back to assessing your own risk or the risk of loved ones around you. Like, if you have a 90-year-old parent living in your house, you may want to take extra precautions so that you don't bring it home. And there are different risk scenarios. So, it's a beautiful day. If I'm outside, that's safe, right? We know being outside is safe. If I go to a supermarket, right now, I'll put on a mask because I know disease is increasing in the community. Will I go to a full movie theater? Probably not. But if I did, I would definitely wear a mask there. So, uh, whatever one chooses, I guess we have to be respectful of what they're choosing to do. And I think as much as probably when this first started out, there were people not wearing masks who are marginalized. I don't want to see the reverse where people wearing masks get marginalized. So it's not just the vaccines, but there are other individual decisions that we need to make and to decide, to protect ourselves and our loved ones.
Okay. All right. Thank you so much, Dr. Zuckerman and Dr. Vader, for those updates and that information. That was really helpful. We do have some questions coming up in the chat, but I do want to invite everyone to take this opportunity. You can enter your question in the chat. You can unmute and hop in and just ask your question. This is a fantastic chance to ask your questions and have them answered by some really good teachers. So please hop in. I'm going to start with some of these questions in the chat. I know Grace had a question. Grace, did you want to jump in and ask?
Yes, thank you. Hi, I have a question for you. Yesterday, I was at my physician's office and we came across talking about COVID. And I'm quite sure she was talking about the BA2.12.1. Now, she goes on all these sites and does all the Zoom with Harvard, the latest updates on the COVID. And what she told me scared me. Usually it doesn't, but what she had explained to me yesterday really scared me. And what she had said to me was that this new variant is very highly contagious, which you had said, and there is no therapeutics right now that can help with it. She explained that it does infect the lungs, but the back part of your lungs. And she said the best thing you can do is wear a mask and wash your hands and use all the gels and everything for the, so that's why I hopped on. I'm like, I'm a little scared about this. So I just want to listen to your perspective. You didn't mention anything about, is this like highly contagious? Yes, you said it causes death, but what she's telling me, is that true? Is that exaggeration?
Yeah, so thanks for that. It is more infectious than previous strains. Again, that's what the virus wants to do, right? It wants to spread around to as many people as possible because it doesn't want to go bye-bye. It wants to stay with us, forever. That's its survival practice. So it is more infectious because we're seeing disease in people who've been recently infected with Omicron or recently had vaccination. It has the ability to, it's changed a little bit, so it does have that ability to evade some of our immune system. I have not seen anything to suggest right now that it's causing more severe disease than things that we've seen previously. If a patient saw me in the office, I probably would say the same thing: wear a mask and and wash your hands, and depending on your what your situation is here, but here is, I'm not giving my if you were one-on-one with me in the office, I would probably be much more vocal about some of the masking and other measures to protect yourself. What we don't know, so there are other, so COVID's caused by a coronavirus, right? And There are other coronaviruses that cause the common cold. There's actually 4 types that causes the common cold in humans. And they occur year round, right? So winter, we get more colds because we're all, huddled together. But I'm sure if you have kids or grandkids in daycare centers and, in camps, you see how, frequently there are cold outbreaks that occur. So I think the unknown is, will this COVID virus act like these other coronaviruses and just, cause potential disease, throughout the year, not just in wintertime, like mainly the flu virus does. I think, we still have to learn more about that. And it really hasn't declared whether there'll be a seasonal variation or not. I think I wouldn't be, I don't know where she got or he got his information, but I'm not aware of any worse outcomes. In fact, we're seeing slightly different because we haven't seen an increase in our hospitalizations at Hackensack or in the ICUs. I don't know, Tom, do you have any other comments?
Well, I just wanted to make one point. I think, with all due respect, and again, I know it's all secondhand, but there's no question that the statement that there's no therapeutics available for this is absolutely incorrect.
Yeah.
I mean, first of all, there's the preventive step, which is vaccination, because no matter what, even though this is obviously very highly transmissible, you're still better off already being vaccinated, and you will have, it provide you an immune response. You're not immunocompromised. You'll have an immune protection from this virus. And the second thing is, should you get ill, it's really wonderful. I mean, not only do we have the I think it's a medical miracle that we have the vaccine, but in addition, the pharmaceutical industry has also developed a very effective oral medication that is available and seems to work against this virus. So that's an important statement. So it is absolutely not true that we don't have good defenses against this particular strain.
Right. Yeah. Thank you. I forgot about that point.
Thank you very much for that. Now, maybe I've just eased my mind a little bit. I was a little panicky. Thank you.
Sure.
Okay. Next question is related to pregnancy. I've been told that COVID during pregnancy can cause higher risk of blood clots. Can you speak to this risk?
So COVID is associated with blood clots in pregnancy or not in pregnancy. I don't know, and pregnancy is also a condition where blood clots are more common. So it wouldn't surprise me that the two would work together and put a woman at greater risk for blood clots. COVID also can, besides causing, pneumonia, the lung disease associated, the respiratory disease associated with COVID, it also can cause preterm labor and preterm delivery, as well as other complications. So yes, it wouldn't surprise me at all if COVID is associated with blood clots during pregnancy, because it's associated with blood clots even in the non-pregnant individuals. But that's really only one of the risks associated with the disease. And again, there's no question that vaccination is well, first of all, it's safe, but secondly, it's certainly much safer than getting the disease. And even if you're unfortunate enough to get the disease, again, you'd still benefit from the vaccine if you have the vaccine during pregnancy. There's no need to wait. People undergoing infertility treatments can get the vaccine. People who are newly pregnant can get the vaccine. There's no limitations.
Thank you. Next question, is the manner in which the COVID-19 virus evolves unique to COVID? Are these variants and their ability to circumvent antibodies unusual, or are these patterns typical / similar to how most other viruses evolve and replicate?
Great question with multiple answers. Not all viruses do this. So this maybe is more common with respiratory viruses. So measles as a virus, chickenpox as a virus, they don't changed. I mean, it's been the same measles virus that's been around for decades and same chickenpox virus that's been around for decades. So those are very stable viruses. Some of the respiratory viruses can change over time, the model really being the flu virus. So we know that flu, as it goes around the world and it's reproducing, there are going to be times when that reproduction goes a little awry and the virus changes a little bit. And again, every little change that the virus has gives it an advantage because we're susceptible to that virus with that change, as opposed to it staying the same and we've already been vaccinated or infected, and then we can protect ourselves with antibodies. So the flu virus has these subtle changes each year as it circulates around the world. And, we see spikes of flu during the season, and, some years it's worse than others. But the flu can also have a major change. And when the flu has a major change, that's when something like a pandemic can emerge. So the last, major change that we saw with the virus was in, I guess it was 2009, when we had the kind of that mini flu pandemic, right? Because that was the virus changed significantly. So the coronavirus is acting similar to that. I think what is maybe a bit unexpected, I don't know if it's unexpected or maybe when it wasn't fully appreciated, was how frequently this virus changes. So coronaviruses, the ones that cause the common cold, tend to be very stable and don't have major changes. Clearly, this is acting differently. And, we had Omicron, 3-4 months ago, and now we have 2 subvariants related to that. So there clearly is that this particular type of coronavirus is more likely to have changes when it replicates. And hopefully that answers the question.
Okay. How long would you potentially test positive after having COVID?
So that depends what test you use. So there are different type of tests. There's the antigen test, which is the one that if you ordered from the federal government, you get in the mail. And then there are these other tests called Pcr tests or nucleic acid tests, where they go to a lab and they, run it. The PCR tests are very sensitive, meaning that if there's even a little small pieces of a virus present, you may still test positive. The antigen is not as sensitive to that. So when you get infected, the amount of virus goes way up and then starts going down. And the antigen test usually will become negative first because it's less sensitive, and then the PCR later. In a normal individual, healthy otherwise, it probably, the antigen test can probably persist for 5 to 10 days. It is possible that the PCR tests persist for several weeks. And if you are immunocompromised, people may remain PCR positive for a longer period of time. But just being positive does not mean that you're contagious or infectious to others. It just probably means you have some dead viral particles still circulating around in your nose that's being detected. It is no way equivalent to being contagious. most people are not contagious after that, 10-day period.
How long do you need to wait after testing positive for COVID before you can get a vaccine or booster?
The recommendation now is you don't have to wait. Once you're, done with your isolation period, then, you're eligible to get the vaccine. I think when the vaccines first came out, people talked about waiting, but if you get vaccinated, there's no increased side effects or complications from the vaccine. So really, any time after an infection is you're eligible for a vaccine booster dose.
Okay. We have a question from Elaine, who I think may have hopped in a little later. She has a question about the booster shot. Is it worth it to get the second booster shot if over 60? I have heard it does not offer enough protection anymore to bother, that I would be better to wait till the fall, as they may have a better option at that time.
I can take this one. Dr. Zuckerman addressed this earlier. Again, it's an individual decision for those. I don't know what Elaine's overall health is in terms of whether or not to get the fourth shot. I think this concept of maybe I better wait because it'll be better in the fall, or the timing will be better in the fall, and all of that. My reaction to that is, again, I'm 58. I just got my booster a week ago. My reaction to that is, I'm all set to get this new and improved Wonder booster in the fall, but I'm going to get my regular booster now. Now, I can tell you, it's possible to be a more dramatically better booster in the fall, but more likely it'll just be more of the same. So my feeling is you don't have to game this. You don't have to figure it out. All I see is cases are going up. And again, for people that are overweight and over 50, like me, I'm at increased risk for disease. And so I don't want disease. And so I got the booster. So again, as I think Dr. Zuckerman said, you really should discuss it with your healthcare provider. But to me, I don't think it's that difficult a decision, frankly. And again, I'm perfectly prepared to get another booster. So this is May. So maybe in 5 months, there'll be another booster. I'll be ready to get another booster in October.
Okay. Elaine says, thank you. Does the COVID infusion have any side effects with a patient with cancer and COVID?
I assume that's the COVID infusion. That's the antibody infusion. There's also, there's also a treatment infusion, but I assume that's probably the antibody infusion.
Yeah. So,
tolerated.
Yeah, one of the treatments is called monoclonal antibodies. So essentially, it's an infusion, and it's giving you large amounts of antibody against the spike protein. Similar to what we try to produce when we get vaccinated. And there is no that I'm aware of any increased side effects with individuals with cancer or other conditions. Sometimes there are some reactions when you get an infusion, but it's not really particular to any other comorbidities that someone may have. I don't think I mentioned this earlier, but I will say that there is a monoclonal antibody. It's not an infusion, it's an injection that you can give to people who are whose immune system doesn't work. And it's given as another means to try to prevent you from getting infected. So it's a prophylaxis medicine. So it's or injection. So people who get it, in the study has shown to have a lower risk of getting COVID than people who have not got it. So, if you're severely immunocompromised, again, this is something I would discuss with your provider, but that is also another piece or in our arsenal that could help protect us depending upon our situations.
Okay. So I think we covered all of the questions in the chat. If anybody wants to hop in and verbally ask a question, please feel free to do so. I also have a list of questions that we gathered from participants and staff. If nobody has a question, I have a question. Okay, I'm going to jump in. So we recently surveyed a number of families about vaccination and concerns they might have around it. And the largest concern, or one of the larger concerns, was the side effects. My question about the side effects is, I just spoke with someone today who had her second booster, and she said she had a bad headache and pain in her arm, which is different from her first booster. She experienced nothing. So from shot to shot, people seem to have different reactions, and from person to person, they have different reactions. Can you talk a little bit about why it looks like this, why it's different for everyone, and what it means? Does it mean anything?
Yeah, that's a good question. No, I don't think it means anything. I had more of a reaction after my second shot than I did, when I got my booster. So I'm not sure. We do know that, let's see, when the first studies came out, younger people tended to have more side effects at the injection site or fevers than older people. And that's probably because the immune system is maybe a bit more robust and active in younger individuals than an older one. And that probably holds up whether you're getting your second dose or your booster or your second booster. I imagine that the likelihood is more common in younger individuals than older ones. But besides that, I don't think there's any rhyme or reason why certain people get side effects and certain people don't.
Yeah, I've never heard anything or read anything about it. It is fascinating to me. I mean, I was definitely had a significant impact from the first two. My third one made no impact whatsoever, and the fourth one, I felt it a little bit. So it does seem to be extremely variable. And I think, as Dr. Zuckerman alluded to, the immune system is an extraordinarily complicated system, and it's subject to influence of hormones. And the fact that it responds differently at different times, to me, isn't surprising given its complexity, and I would say to some extent its unpredictability in general. Never mind its response to vaccines, but it works.
That's really interesting. Is there so for women who have their menstrual cycles, if this is impacted by hormones, is there a better time in a
Oh, no, I didn't mean to imply. What I meant was like stress hormones can influence our immune system. Just as an example, I wasn't saying specifically. I don't know. I'm even as a gynecologist, I don't believe there's been any demonstrated impact of estrogen or progesterone or GnRH or FSH or LH on the immune system. But I do know that substances like cortisol can impact the immune system. So that's what I was alluding to. But I don't think, I certainly wouldn't have any concern about your body's immune system's ability to respond depending upon the cycle time.
Okay. Anybody have any questions? I'm going to ask my next one if not. So I was reading an article that was trying to link COVID with the rise in hepatitis cases in children. Is there a link? Do we know? Can you talk a little bit about that? Should parents be worried about that?
I'm not aware of a link right now. Not to say, this is still kind of an evolving situation. So adenovirus is, it's like one of those respiratory viruses. And I think, what's interesting is as we've gone out and wearing less masks in public, we start seeing this. We still see flu in the community, which in May is very late. But I'm sure all this is related to us not wearing a mask. And these viruses, some of these other viruses, just shows that influenza is less transmissible when people are wearing masks than not. And so I think it's more indicative of the way we're approaching things than actually a connection between the coronavirus and adenovirus causing the hepatitis. But there are some very smart people looking at it right now.
Thank you again, everyone, for being here with us tonight. Thank you so much, Dr. Zuckerman and Dr. Vader. This was so helpful.